So porphyrias are a group of medical disorders which are associated with a defect in heme metabolism. Okay. So they are characterized by two things. The first is depending upon the clinical feature, whether the skin is involved. So this usually occurs secondary to photosensitivity. So porphyrias are photosensitive, which results in skin involvement. And the second is neurovisceral involvement. So that usually is most commonly that is seen as abdominal pain. Also, the porphyria is characterized by the accumulation of heme precursors. Okay. So depending upon the metabolism that is defective, certain heme precursors are accumulated, and based on that, porphyrias are again identified. Okay. So let us look at the porphyrias. So clinically, porphyrias can be either acute, non-acute, hepatic or erythropoietic. Now what are acute porphyrias? Now acute porphyrias are characterized by accumulation of two heme metabolites. One is ALA, that is aminolevulinic acid, and the other is PBG or porphobilinogen. The important thing is both ALA and PBG are neurotoxic. Okay, they affect the nerves, and this is why they have acute presentations. Okay, acute presentations in the form of neurovisceral symptoms, out of which most commonly is the acute abdominal pain. Now, why acute abdominal pain occurs? This is because ALA and PBG, they affect the sympathetic as well as parasympathetic nervous system of the GI tract, and as a result there occurs decrease in intestinal motility, which gives us an impression of pseudo obstruction, and this results in colicky abdomen pain. This is the most common acute presentations of acute porphyrias. It can also affect the peripheral nerves, under which you can have tingling, numbness, weakness. Okay, and this occurs because the axons of the nerves are affected. Okay. It also affects the autonomic nervous system. Okay. How does it affect? Because the ALA interferes with the autonomic ganglia, and this results in presentations of nausea, vomiting, tachycardia, etc., and other autonomic dysfunctions. Okay. Also, few psychiatric symptoms are seen. Okay, for example, from anxiety to confusion to hallucination. This occurs because again the porphyrias, they interfere with the excitatory as well as the inhibitory neurotransmitters, that is glutamate and GABA. So there is an imbalance of this excitatory and inhibitory neurotransmitters, which results in all these psychiatric manifestations. So what are the acute porphyrias that are there? So it includes the first one, ALA, dehydratase deficiency. Then the most common one, acute intermittent porphyria, hereditary coproporphyria, or variegate porphyrias. So these are the four acute porphyrias that present with acute manifestations. Okay, let us first look at the ALA dehydratase deficiency. Now ALA dehydratase deficiency, it is mainly a autosomal recessive condition. So that means a homozygous condition will be symptomatic, whereas a heterozygous condition will be asymptomatic. Now if you look at the heme synthesis, okay, it occurs partly in the mitochondria and partly in the cytoplasm. So in the mitochondria, we have glycine, which is the simplest amino acid, and we have succinyl-CoA, okay, which is an intermediate of the TCA cycle. So glycine combines with succinyl-CoA and leads to formation of aminolevulinic acid, okay, delta aminolevulinic acid, and the enzyme is aminolevulinic acid synthase. Okay. So here let me point out that succinyl-CoA is an intermediate of TCA cycle, which is being used for synthesis of heme. Okay, so this explains the anapleuritic role or the synthetic role of intermediates of TCA cycle. Okay, so TCA cycle is has a anabolic role as well as catabolic role, which is known as anapleuritic role of TCA cycle. So here we are seeing the anabolic role of TCA cycle. Okay. So glycine combines with succinyl coenzyme A, leads to aminolenic acid synthesis. Aminolenic acid then undergoes dehydration with the help of the enzyme ALA dehydratase, okay, and leads to formation of porphobilinogen. So our condition is ALA dehydratase deficiency. So we have a defect in this enzyme. So when we have a defect in this enzyme, what is expected to be accumulated is aminolevulinic acid. This will be accumulated and porphobilinogen will be in less concentration. Okay. Let us look at the other part of the cycle. The porphobilinogen combine, again 4 porphobilinogens combine to form is uroporphyrogen, then leads to coproporphyrogen. The enzyme is uroporphyrogen decarboxylase. Then coproporphyrogen leads to, again through intermediate steps, ultimately leads to formation of heme. Okay. Now if we have a deficiency of this enzyme, so can we say that ultimately the heme synthesis also will decrease? Yes, because we have a defect over here. So the down pathway also suffers. So as a result, in conditions of deficiency of ALA, heme production also will decrease. Okay, so when heme production decreases, now heme has a feedback inhibition on ALA synthesis. Okay, when the body produces less amount of heme, it increases its own production. Okay, so in this case, when the heme production is decreased, this will stimulate ALA synthesis. So more and more of ALA synthesis activity will increase. So as a result, we will have increase in aminolevulinic acid or ALA, which is, we all know that it is neurotoxic. So ALA concentration is increasing by 2 mechanisms. One is because of ALA dehydratase deficiency and because of increased activity of ALA synthesis, secondary to decrease in heme. Okay. Now when ALA is increased, this will start to excrete in the urine. Okay. Now what happens is we have this enzyme uroporphyrogen decarboxylase. Okay. Now it is seen that the activity of uroporphyrogen decarboxylase increases in this setting. Okay, when there is ALA dehydratase deficiency. Okay, so as a result, this activity, the enzyme activity of uroporphyrogen decarboxylase increases. Okay, so this leads to increased production of coproporphyrogen. This coproporphyrogen also is increased and it is excreted out in the urine. So in the urine, we get increased activity of increased concentrations of ALA as well as coproporphyrogen. Now because ALA is neurotoxic, it leads to neurovisceral symptoms in the form of acute abdominal pain. Okay, this is usually seen in the age group of 15 to 40 years and the pain is maybe very severe and even life-threatening. Okay. So how do we diagnose this? We diagnose this by looking at the ALA dehydratase activity in the RBC. If it reduces less than 10%, we are dealing with a possible ALA dehydratase deficiency. Okay. Also, we can look for ALA gene mutation. Okay, so these are other investigations which are useful for ALA dehydratase deficiency. Now ALA dehydratase, apart from the genetic influence, apart from the defect in the gene, ALA dehydratase deficiency also occurs in 2 important conditions. Okay, first one is lead. In case of lead poisoning also inhibits ALA, lead also inhibits ALA dehydratase activity. So you will have the same symptoms in conditions of lead poisoning. And the second is when there is accumulation of succinyl acetone. Okay, now this succinyl acetone is seen in conditions of type 1 hypertyrosinemia. Okay. Now if you look at the metabolism of tyrosine, okay, so tyrosine comes from phenylalanine and ultimately tyrosine is broken down into fumarate and acetoacetate. Okay, so it is both glucogenic as well as ketogenic. Now this is the enzymatic defect in type 1 hypertyrosinemia. Here you have is defect in femoral acetoacetate hydroxylase. Okay, so when this hydrolase is defective, femoral acetoacetate is not broken down into fumarate and acetoacetate and leads to accumulation of femoral acetoacetate. and its isomer form, that is menyl acetoacetate. Now both these fumarate acetoacetate and menyl acetoacetate form succinyl acetoacetate, which is converted to succinyl acetone. Now this succinyl acetone inhibits ALA dehydratase. So that is why in case of type 1 hypertyrosinemia, there also is deficiency of ALA dehydratase, and you get the manifestation of acute porphyria. Now let us look at acute intermittent porphyria. Okay, so acute intermittent porphyria is an autosomal dominant condition. However, okay, for this acute intermittent porphyria, the enzyme which is defective is PBG deaminase or porphobinologen deaminase. Okay, so this is again, we have the same heme synthesis. So here the enzyme which is defective is porphobinologen deaminase. Okay. So how do we remember this? Two ways. One is acute intermittent porphyria is, as the name suggests, it is acute. So what is going to be accumulated? Okay, two things. One is ALA and the second is PBG. Now ALA is ALA dehydratase deficiency. ALA was accumulated. So here we are having is accumulation of PBG or porphobinologen. So we have a defect in porphobinologen deaminase, which is also known as HMB synthase or hydroxymethylbilane synthase. Okay. Now, as long as the activity of porphobinologen is 50%, okay, instead of 100%, let's say there is some deficiency of porphobinologen deaminase activity. The activity is reduced to 50%. So even when the activity is reduced to 50%, porphobinologen does not accumulate. Okay, so whatever porphobinologen is formed, it is converted to hydroxymethylbilane and the process continues. Okay. Now what if there is increased concentration of porphobinologen? Okay, so when this can happen? When the ALA synthase activity is increased. So when we have increased ALA synthase activity, more amount of amino levulinic acid will be formed, more amount of porphobinologen will be formed. Okay. So in case of acute intermittent porphyria, 50% enzyme activity was sufficient to convert all these porphobinologen to hydroxymethylbilane. But if the concentration of PBG increases, the enzyme is not sufficient to convert all these PBGs into hydroxymethylbilane. So as a result, PBG will increase. Okay, so when does this PBG increase? One mechanism is when the ALA synthase activity increases. Okay, now when will ALA synthase activity increase? These are the conditions, possible, most likely conditions. So when somebody takes in alcohol, alcohol increases ALA synthase activity, which increases ALA, which increases PBG. Similarly, steroids, both exogenous as well as endogenous steroids, will increase ALA synthase. Okay, certain drugs are there. Somebody who is having weight loss or is taking low carbohydrate diet. Okay, so carbohydrate inhibits ALA synthase. So somebody who is taking low carbohydrate diet, so this inhibition is lost and there is increase in the activity of ALA synthase. Also, the activity is increased under conditions of premenstrual syndrome. Okay. So under again hormonal. So these are the conditions which increases ALA synthase activity, and you will have increased concentration of porphobinologen. So this leads to again acute symptoms. So we will have neurovisceral attacks, okay, which is most commonly seen in the abdomen because the parasympathetic and sympathetic nerves are involved. Okay. Now what is important to note is that this pain here is neurological and not inflammatory. Okay, so this colicky pain which is happening in acute intermittent porphyria, this pain is neurological in origin and not inflammatory. Okay. The other neurological symptoms that happens is nausea, vomiting, constipation, tachycardia. Why does this occur? Because again, ALA, PBG, which is increased, they cause autonomic dysfunction, okay, of the autonomic nervous system. Peripheral motor neuropathy also is seen. Again, we have explained this, occurs because of increased concentration of PBG and ALA. And mental symptoms, they range from anxiety to hallucinations. Now we will have increase in aminolevulinic acid or ALA, and increase in PBG, both are elevated in urine. Now what is important to note is somebody who has an acute attack of acute intermittent porphyria, if in their urine PBG level is normal, then it is unlikely that the pain or the attack is because of acute intermittent porphyria. Okay. And also the excess of PBG which is present is spontaneously converted to uroporphyrinogen 1 or coproporphyrinogen 1 isomer and not 3 isomer. Okay. So this is what is elevated in the urine. How do we treat it? We treat by giving high carb diet. Okay, because high carbohydrates, they inhibit ALA synthase 1. So once the ALA synthase 1 is inhibited, automatically the down pathway, the intermediates decrease. The second is, again, we give exogenous heme, which is known as hematin, which also inhibits ALA synthase 1. Okay, so this is about acute porphyrias. Now let us look at non-acute porphyrias. The non-acute porphyrias are characterized by skin involvement. So basically photosensitivity. Now why photosensitivity occurs? Because there is accumulation of porphyrin precursors. Okay, and porphyrins are ringed structures, and these ringed structures are photosensitive. So this results in the skin which is exposed to the sun. Okay, because it is photosensitive. So the sun exposed parts, they will show photosensitivity, they will have hyperpigmentation, can develop painless blisters, can then later on develop scars. The skin becomes fragile. So all these skin symptoms are seen with non-acute porphyrias. Okay. What are the non-acute porphyrias? Most commonly Porphyria cutanea tarda, congenital erythropoietic porphyria, erythropoietic protoporphyria, and X-linked erythropoietic protoporphyria. So these are the 4 non-acute porphyrias. Now let us look at first one, that is Porphyria cutanea tarda. It is the most common porphyria that is seen. Okay. 80% of this case is sporadic. That means no genetic involvement is there. Sporadic cases. Okay. 20% it is autosomal dominant. Okay. So inheritance from parent to offspring will be seen in 20% of cases. Otherwise 80% it is sporadic. Okay. Here the defect is that of uroporphyrinogen decarboxylase. Okay, uroporphyrinogen decarboxylase. So in this case the carbon dioxide is released. If you look at the step previous when we have discussed heme synthesis, so there if you look at the activity of this enzyme uroporphyrinogen decarboxylase, it causes the loss of carbon dioxide and results in formation of coproporphyrinogen 3. Okay, so this enzyme is defective, uroporphyrinogen decarboxylase. So as a result we have is increased concentration of uroporphyrinogen. Now here again 20% is seen in case of autosomal dominant. Okay, and 20% activity is sufficient to not cause the disease. Okay, even if the uroporphyrinogen decarboxylase 20% activity is there, you will not have Porphyria cutanea tarda. Okay, if the concentration goes below 20%, then the symptoms will occur. What are the symptoms? Photosensitivity. Because of this enzymatic defect, this leads to accumulation of uroporphyrinogen, which is ringed porphyrins, uroporphyrins, which are photosensitive. The photosensitivity is again, it is also seen with liver involvement. So in these patients, liver function test is deranged or altered in 50% of cases. And these patients may have a underlying chronic liver disease. Okay, so those patients who are having Porphyria cutanea tarda, these patients may be around 50% may have an underlying chronic liver disease. What is another important thing to note is Porphyria cutanea tarda is strongly associated with alcoholic liver disease, HIV, HCV, iron, elevated iron concentration, and estrogens. Okay, so these are strong associations which are seen with Porphyria cutanea tarda. Okay, so when you have, if somebody is having alcoholic liver disease, the chances of in them showing photosensitivity is increased. Neurological symptoms are absent. Why? Because we don't have accumulation of ALA and PBG. So uroporphyrinogen is excreted in the urine. Okay, it gets substituted and forms heptaporphyrin, and porphobilinogen is absent in urine. Okay. Treatment is we do repeated phlebotomies to reduce the hepatic iron. Okay. And hematin is given, which again inhibits ALA synthase. So when you inhibit ALA synthase, the whole of heme synthesis reduces, and the porphyrin concentration also reduces. Okay, so this was about Porphyria, cutanea, tarda, and Porphyrias in general. Now, can we screen them? Yes, Porphyria can be screened by taking urine samples, and we can see a change in urine color from normal pale yellow to brown and red. Okay, why does this occur? This occurs because of photooxidation of porphobilinogen, which is present to uroporphyrin or porphobilinogen. Generally starts within minutes to hours upon exposure to sunlight. Okay, so when porphobilinogen is exposed to sunlight, within minutes to hours it changes, it undergoes oxidation, which results in change in color. Okay, so the visible change of color is from yellow to reddish brown, is usually noticeable from 30 minutes onwards. Okay, so this is one way how we can screen for porphyria. Okay, thank you.